Good morning, everybody. It is a great pleasure to be here and present this topic. So, tricuspid regurgitation, just to set the stage, it's a prevalent and undertreated entity, and the undertreatment goes that surgeries are not performed in this population for many reasons. The most important is that they present late, and the morbidity and mortality associated with surgical intervention is usually quite high. But the disease itself, which is, as we mentioned earlier, associated with heart failure, carries a dismal prognosis when left untreated. So the medical community has forgotten this valve. So notoriously, this valve has been referred to as the forgotten valve. But now, over the recent 5 to 10 years, we have more and more publications regarding the epidemiology, the prognosis, and the treatment of this entity. And this gives some promise. Most of these patients are undertreated because the most prevalent symptoms are leg edema and some fatigue. They get some diuretics, they get better. But if we look at the progression of the disease within 5 years, people get a lot worse. And additional risk factors to that is the presence of afterload mismatch of the right ventricle, so some burden to the pulmonary artery circulation, and of course atrial fibrillation. So the medical community, having recognized the unmet clinical need, which is a huge one, even bigger than the mitral or the aortic valve, came with this state-of-the-art paper in Eurointervention that summarizes the phenotypes of tricuspid valves. So we've realized now that only half of the patients are truly tricuspid. We have split leaflets in the posterior, anterior, septal location, sometimes even 2 split leaflets, so it could be quadracuspid valve in a few patients. And also, we have categorized the functional anatomy of this population in a similar fashion to the mitral valve. So we have atrial dilatation, we have ventricular dilatation and tenting and tethering of the leaflets. We have, of course, primary problems, but there's a whole new entity that is related to wires and leads from pacemakers and ICDs that complicate the phenotype, either because they're just present there or they interfere truly with the valve. And of course, we have to think and we have to start to recognize the coupling between the right ventricle and the pulmonary circulation. We have to find a way to evaluate the right ventricular function in a more appropriate manner. Echo is the traditional way, but let's not forget other modalities such as MRI, invasive testing. Maybe 2 simple parameters, measurements have been presented, like this ratio, TAPSI to RVSP. If it's a big one, if it's quite high, it means that there is reserve. If it's not, that means that the right ventricle may not have a reserve. But let's not forget about the patient. These are morbid patients with renal and liver problems and frailty, even more so than some of the other valve problems. So how do we target this tricuspid valve? Well, to start with, leaflet therapy is, again, the predominant one, with the TEER being the first choice, approved certainly in Europe with 2 devices. And Cardioband has actually been, as a direct annular therapy, the first device to receive CE mark, but is not used widely. And there's a lot of research going to the orthotopic TTVR replacement and also to the heterotopic TTVR. And how do we choose these patients? Now, that's an interesting topic. Let's go back one step and look at the TriClip delivery system. Recently, we have seen the Triluminate trial, which is the first ever trial to compare an intervention to an outcome of the patient. And here are the characteristics of the patients. All of them had good ejection fractions and low wedge pressure, so left ventricle has never been an issue. Isolated, predominantly atrial tricuspid regurgitation in this population. And the primary endpoint was met. First, the tricuspid regurgitation was significantly reduced to moderate or less. This was the goal that was set by the trial in 87% of the patients and 30 days, and that result was sustained up to 1 year. And the primary endpoint was largely driven by the quality of life improvement. And because there's always a bias, this is an unblinded study, people have an intervention and they are inclined to feel better, they categorize the KCCQ improvement according to the degree of residual tricuspid regurgitation, and they found that if you had a significant reduction, you had a better quality of life improvement, so that kind of eliminates that bias. What is very important, and we have seen that in clinical practice, is that it is a very safe intervention. Very few people suffer complications or deaths. The only caveat being the single leaflet detachment, which is still at 7%, quite high. We are not used to that numbers when it comes to mitral intervention. So how do we define the success? This is one pertinent question. We define it by moderate or less in most of these trials, so 2+ or less. We don't go to trace or none, that we have set the goal for mitral regurgitation, because this is tricuspid valve. And what are the patient characteristics that predict success? We don't know, but certainly if we have a left ventricular problem and a left valvular problem and treatment, that's a big minus. And of course, looking in the pulmonary hypertension. If the patient has got a liver problem, so cardiohepatic syndrome, we know that these patients do worse. So when we select patients for intervention, we should keep that in mind, that some of these patients might have missed the opportunity to have an early treatment, and we have data to support that. But what about the other clinical characteristics that predict success? It's still under investigation. It is complicated because it's a complex interplay of various system organs. Let's go to the technical issues. I mean, how do we predict what patient will have a successful TEER? Clearly, the length of the leaflet, the number of the leaflet, whether it's 3, 4, or 5, the origin of the jet, the severity of the gaps, and of course the presence or absence of leads are very, very important questions. Of course, the imaging window is very important. If you cannot see what you're doing, you're not going to be able to do. And of course, sometimes you may have unpredictable technical issues, such, for example, the line of attack, the angulation of the IVC that you cannot predict up front. So clearly, if we have long enough leaflets, that the sum of these leaflets are bigger than the size of the annulus, this is a good predictor. If your location of the jet is anteroseptal, then that's a good thing, because it's easier to attack, you see better. The number of leaflets. Clearly, 3 leaflets are better than 4 leaflets, because you have less problems to open up clefts or indentation between the leaflets and create new jets of regurgitation. And of course, the coaptation gap. Now, a big gap may be difficult to bridge, particularly if the leaflets are short and tethered towards the ventricle. So all this we have to think about. What about pacemakers? Now, pacemakers may be causing the problem or maybe just bystanders to another problem. So, for example, you may have an atrial dilatation, severe functional tricuspid regurgitation, and have a lead. If you look at the Triluminate EFS, a few patients have been excluded because they felt that the lead was interfering, but the rest of the patients that they had a lead and treatment, 10 out of 12, not a big number, of course, they had similar outcomes to the patients without a lead. And of course, it's quite interesting that the earlier that we intervene to this valve, we're going to have a better outcome to avoid excessive remodeling, which may make us have less outcomes. There is an effort to create a group similar to the mitral, so green, yellow, or red lights, and clearly the green ones are the ones that we want to attack. Unfortunately, the red ones are the ones referred to us because people and mainly cardiologists feel that they have to send the patient for interventional therapy when they're too sick, and too sick means ventricle that is already remodeled and tricuspid valve, which is very big. So let's have a look at this patient. This is a typical patient that is treated with tricuspid. You can see the morphology is 3 leaflets. There is an anteroseptal location of the jet. The leaflets are very long, and it's easy to put 2 clips and have a very nice result. This is another patient that has a significant anteroseptal location. Here, however, you can see that the anterior leaflet perhaps is divided, and it could be that the patient has got 4 leaflets. However, long leaflets, mobile leaflets, easy to grasp, and with 2 clips in the anteroseptal location, you have a very decent result in this patient too. So these are the patients that we can treat reliably at the moment. If you have a patient with a huge gap or short leaflets or tethered leaflets, it might be a problem. What do you do about these patients, however? You have to do something. What about heterotopic tricuspid replacement? Now, in Europe, this is becoming quite popular. There is a theory, and there are devices out there. First, we put balloon expandable valves in pre-stented areas in the SVC and IVC. There is a dedicated device which is personalized, the Tricento for that. But what we really use in Europe is the trick valve that I'm going to show you in a minute. These are the patients that we select. Usually we want patients with significant overload of the right side, and of course they are non-eligible to TEER, but we want to exclude patients with severe pulmonary hypertension to avoid severe right ventricular afterload mismatch, and of course there are the unknowns about the right ventricular inotropic reserve. This is a device, 2 dedicated self-expanding valves to the SVC and the IVC. This is one of our patients. There's a complex workup going to assess the length and the width of the SVC landing zone and the same with the IVC landing zone. I'm not going to go into the details. Of course, when we treat these patients, so these are the measurements we take. And this is the implantation of the SVC valve. You can see we have the left innominate vein as a marker and the right pulmonary artery using the Swan-Ganz catheter. And then gradually we deploy this valve. It's a preloaded valve, 28 frames. You just insert it inside the patient and you upload the valve. And then you move to the IVC, having your marker into the superior hepatic vein, and then gradually you deploy. It's a procedure that takes about half an hour, and very impressively you see reduction of the pressures in the IVC. We did that with general anesthesia and TE control, but it can be done under conscious sedation on fluoro only. So in general, tricuspid interventions will become more popular in the future. They have to. There's a huge unmet clinical need out there. People are undertreated. Surgery is falling short for that. And careful clinical evaluation, multidisciplinary heart team is required, even more so than the mitral or the aortic position. Of course, TEER at the moment is the treatment of choice, having at least 1 study showing some benefit, even for quality of life. Heterotopic at the moment is a promising alternative to patients that cannot be treated. We are eagerly awaiting for some orthotopic replacement to see if that will move the field forward. Thank you very much for your attention.
Excellent. That was a great topic, and this is a great picture of Interbalkan Medical Center in Thessaloniki. Great. Let's remind everybody, Thessaloniki will host the 2023 Hellenic Cardiology Society Congress mid-October. So everybody mark the calendars. Dr. Lotan will be getting ready. And everybody else who may be attending in the website as well, the internet as well. Dr. Filippatos, any comment? Dr. Pattakos, any comment?
Yes, thank you very much, Vlasis. I think here with the tricuspid are in the same situation that we were and we still are with non-ischemic cardiomyopathy now, or with pneumonia in the 50s. So pneumonia in the 50s was treated with 1 type of antibiotic. Now we have the opposite problem. We cannot choose the right patient for TR, but we have too many devices, and we presume that the result of the one device will have the reduction in TR will have the same effect with all other devices. So, which is the ideal patient? So, you presented all the technical solutions, how we can reduce the TR and improve prognosis. But in my mind, a patient with TR and HFpEF is totally different from a patient with TR and HFrEF. And you know that we can discuss about 20, 30 different etiologies. And in my mind, as a humble clinician, even if we reduce TR if we don't choose the right patients, and I don't think we have enough data, I don't think that we have long-term outcomes that we need. This is the first, I think, an important question in the mind of the clinician. How can you help us from your experience without long-term outcome data to decide who to send? You asked to send the patient earlier, but which patient?
Certainly, it's a very important question, and thank you for that. And clearly, it's the important topic that we all have to consolidate. Now, with the limited data that we have so far, from the clinical standpoint, we need patients that are symptomatic with severe, massive or torrential tricuspid regurgitation that are not decompensated on the left side. So the triluminate profile had a wedge pressure of 20 or less, mean wedge pressure, and ejection fraction which was preserved. Now, even a mildly reduced that is well compensated and nicely treated, I wouldn't exclude. Now, an ejection fraction of 30% or less, for example, on the left side, I think you will all agree that carries a worse prognosis. Now, when it happens to the patient clinical status, a patient with decompensated cardiorenal and cardiohepatic syndrome will do badly whatever we do to him. And I wouldn't really advocate that by treating the tricuspid regurgitation, you're in a position to turn the clock back. But somebody that is symptomatic with severe tricuspid regurgitation, and of course, technically you have good chances of grasping the leaflets and getting a decent reduction, moderate or less, to the tricuspid valve, and the criteria we discussed a little bit earlier, I think we would go for. I think it's worth doing earlier than later, because if you leave this patient a little bit longer, the patient will deteriorate. And let's not forget that we don't have a dedicated medical therapy for right heart failure. We have a lot of therapies for the left, but only diuretics for the right.
So, just one more comment question for Professor Dangas. In my mind, with all these new technologies, even if it's get reimbursed or if it's clinically necessary to implant, to use this device, we need to have a registry to follow all these patients, and this is extremely difficult in Europe. What is the situation in US? Is it, you see what I mean? If you implant, if you reduce the TR with this, all these devices, is this mandatory by FDA to have a registry for these devices or not?
Yeah, well, I mean, this is an interesting concept. And since the beginning of TAVI, it became not exactly associated, but linked with reimbursement. So the participation and the good standing in the TVT registry, which is a national registry of all aortic valve procedures. And the same thing follows for the mitral clip or mitral repair, whoever, and I'm sure the same will go when we have the tricuspid repairs. Okay. And that was the first time that the reimbursement was associated. So a hospital, let's say, it's at the hospital level, not at the doctor level. So for the hospital to get the license to be able to, or approved, however you want to call it, to submit a case to insurance to approve and say, you know, that they have to check the box that says, yeah, I participate in the TCT, in the TVT registry and all that. And of course, you know, if you check the box and you don't participate, that's an option. But every 5 or 10 years, things are reviewed, and if they find out that you checked the boxes and you didn't participate, then you're going to return all the money. So nobody wants that risk. So you know, George, this is how it goes.
George, if I'm permitted, first of all, the term, the underestimated or forgotten valve, worked so much for the tricuspid valve that the last 10 years, each and every Congress devotes to tricuspid so much attention and probably did it good. But give me one only minute to remind one patient I had that I operated 15 years ago for mitral stenosis. And then 8 years ago, she came to a public hospital with 20 kilos above her basic body weight, and she was almost dying. And at that time, it was inserted, and I want Vlas's opinion too, was inserted, I don't remember the name of this sausage, the anchored sausage, in the tricuspid valve. I've never seen
the Forma device, yeah.
Yeah.
What?
Forma.
Forma, yeah.
Yes, Forma.
That
yes.
was this valve was clotting, so it came out. That's good. I'm glad it worked for this patient.
But even with this device, I've never seen a patient 20 kilos with no urine output, ready to go to dialysis. I've never seen in my life a reverse of that patient's future, and now the patient is doing so well with a device that is already not approved to be used. I've never seen such a difference and such an improvement in life quality with this format.
Yeah, well, nothing like what we call etiologic management. If you really knew the reason for it and you take care of it, all things get better. So nothing like that. I think we spoke about the orthotopic replacements, etc., repairs. Let's just focus a little bit on heterotopic. They're essentially putting the two valves in the SVC and the IVC, and things get. I have several questions. Number one, how do you deal with a pacemaker? Existing, pre-existing, or later needing pacemaker, and the real estate in the SVC is rather limited, and we know many patients have even clotting of these SVCs with multiple wires, etc. So how do we figure out that situation when we put in more hardware in the SVC in heart failure patients, perhaps already having pacemaker wires, etc. in, number one. Number two, let's say we put the valves, and then the tricuspid valve is still regurgitant, and then the right atrium becomes ginormous. What's your ramifications of that, of ever dilating right atrium? How do you deal with that?
Excellent questions.
And then I have a third one after we go through these two.
Quickly to answer. I mean, we've only done one case, and I think Aegeia Hospital has done another one. That's the Greek experience.
No, I mean, concept-wise, how do we deal? Yeah, Otherwise, perhaps that's why we don't do many, because if you don't resolve all these, concepts, then you don't want to do it.
All around Europe, over 500 cases, I think they've performed. The company says, and the experience so far says, that pacemaker leads are compatible with being trapped against the SVC wall by the device, the insulation, and the lead doesn't suffer any damage. Regarding clotting, patients will have a proper anticoagulation for 6 months, as you do for any biological prosthesis on the right side. And then usually these patients have got atrial fibrillation, will go on NOAC, so you don't have any clotting. Now, very interesting observation in the patient we did. The V wave on the right atrium was 33 and the mean pressure was 22. I didn't have the pressure trace to show you. Once we put the valves, the IVC, the V wave went down to 15 and the mean wave to 11. So we have a significant reduction by 50% on the pressures on the IVC. And this is very important for the liver and for the kidneys. But the pressure on the right side went up. So the right atrium had a V wave of 40 and a mean pressure of 27, 28. So the experience that we have, they've got some published experience now, is that over 3 months, the whole right side remodels gradually. Because effectively what the two valves are doing is they reduce the available space for the regurgitant volume, because the regurgitant volume of the tricuspid valve is the whole venous bed. There's no limit to how much the regurgitant volume can be. If you limit that to the right atrium, really the pressures are not that high to dilate the right atrial further, and gradually the right ventricle and the right atrium remodel. There are some data, of course there are limited data, it's small numbers, and I think for that particular stage, we should see this therapy as palliation in patients that have refractory edema and difficult to manage.
Yeah, I think essentially, if you have this elevated pressures in the 40s, ultimately it will dilate. It's just that perhaps it's a last stage, and maybe you don't see that. Now, let me pose that the situation. Some of these patients, because I see Dr. Pattakos and his opinion about it. There's a lot of patients who have, many of the tricuspid patients are actually, in general, potentially operable due to age, etc., if they have primary lesion, but the surgeons are very concerned about hepatopathy and bleeding peri-op. So you see patient advanced tricuspid, maybe not advanced age, maybe could have the surgery, but they can't have surgery. Could it be that we can temporize this patient with an IVC stent valve, that you say that, in order to allow, 3-6 months for the liver to get better? And then, patient is operable, can be operated, and then they can take out this stent and, go their own way. Could it be that this hybrid approach might turn some patients into, could this relieve the hepatopathy after a few months and then they can have hemostasis, the surgeons? What do you think, Strati? Could you take out the IVC stent at the same time, just pull it out?
Yes. George, that's a very good question.
And after the answer to this, Strati, let's move to the next speaker because we are behind.
We're an hour behind, not just behind. Some people, they might miss the summer vacation. If we continue like this, some people will miss the summer vacations.
That would be me, so let's go ahead.
Okay, George.